Olá, bem-vindos à TV SBU, na cobertura do 16º Congresso Internacional de Uro-oncologia aqui em São Paulo. Hoje eu tenho a honra de estar aqui com o Dr. Karim Touijer, que é médico urologista do Memorial Sloan Kettering Cancer Center de Nova York. Thank you very much for being here with us. Thank you. Great sessions yesterday and last day. Well, we're talking about focal therapy. It's currently only allowed in Brazil inside clinical trials. So let's talk about first, what's the best patients selection? In Brazil, we have HIFU and irreversible electroporations. We don't have the other focal therapies. So what's the best candidate for focal therapy?
Thank you, Barbara. Thank you for having me. And it's always a pleasure to be here at this meeting, which is one of the most important meetings in Uro-oncology annually. And yes, focal therapy is a relatively new way to treat prostate cancer. In general, the goal of treating prostate cancer is to successfully treat the cancer and at the same time minimize the side effects. And so we know that radical therapies in the form of radical prostatectomy or radiation therapy are often quite successful in eradicating the cancer, but sometimes there is some impact on the quality of life of patients, mainly the functionality in terms of erectile function, urinary function, sometimes bowel function for radiation. And focal therapy is a treatment that has a different philosophy in the sense that it does not treat the whole prostate. It will treat the area that has the most significant or threatening cancer in the prostate. By minimizing the area of treatments, we could minimize the impact on the side effect and the impact on the quality of life. So that is the objective of focal therapy. It is a great approach, but unfortunately it could not be applied to all patients, because we know that prostate cancer comes in different forms and different risks. Low risk prostate cancer that could be successfully managed with active surveillance. High risk prostate cancer that we hope to successfully treat with different combination of all the therapies that we have. And then there is the intermediate risk, which within this group, it's a wide spectrum. And in the favorable intermediate risk, which would be patients with a ISUP2 grade, Gleason grade or score 7, 3+4, those patients, a part of those patients could be treated with managed with active surveillance. Some of these patients are not candidates for active surveillance, but radical therapy may be too much in terms of side effect. And it looks like those patients would be the perfect candidates for focal therapy. However, beyond just the grade, these patients have to have one index lesion, which is a single lesion that we can see on the MRI, that we can confirm on the biopsy. And so that way we know that's our target that we could treat with focal therapy. And so patient selection is very important. Focal therapy is not the treatment for all patients. It is very successfully applied when we successfully select the right patients for this treatment.
Exactly, that's the great message of all of this. And due to the multifocality, we know that usually prostate cancer, although despite the one lesion we see in MRI, the tumors are usually multifocal. So do you do whole gland treatment with focal therapy?
Yeah, so unfortunately in about 80 to 85% of the time, prostate cancer is involving more than just one area of the prostate, and it's multifocal. But we have to understand that focal therapy often is not a treatment that is going to eradicate all the cancer from the prostate. It's a very pragmatic approach. It's a treatment that's going to treat the cancer that is a threat because of its grade today. And then, even if the patient has low grade, low risk disease in the rest of the prostate, the goal is not to make them cancer-free, but to make them the most threatening cancer free. The rest of the cancer, if it's a low risk, those patients can be followed with active surveillance. And so the idea is to accompany a patient, a man, throughout their life, maybe living with the cancer, but the cancer is not impacting their longevity, their quality of life.
And this is very important for us as physicians and for the patients to understand that. That's a very good point. And in Brazil, we have the HIFU and irreversible electroporation. Could you please explain the main differences and the indications of the both techniques?
Yeah. So we talked about this in the presentation at the Uro-oncologia meeting.
An amazing presentation.
Thank you. And it's important because we do have energy that can kill the cancer cells. But do they perform equally in all type of location type of prostate cancer? We have to understand that the noble areas of the prostate are their neurovascular bundles that have to do with erectile function, and the sphincteric complex at the tip, at the apex, that has to do with the continence. So the closer we get and we apply energy to these areas, we could cause some harm. And so the energy itself in the laboratory, the various energies, can kill the cancer cells because it goes to extreme temperature, or it causes some non-thermal energies that cause some modification in the membrane cells and allows the cells to die. For example, HIFU is a good therapy, is good energy. It has been applied for a number of years, so there is a wide experience with HIFU. And HIFU performs better, as we said in the presentation, in the posterior tumors rather than the anterior tumors. That's what the knowledge and the literature so far tells us. Cryotherapy, which is a thermal energy that freezes the cells, has an advantage because you can control the ice ball and you can control the area that you treat. Cryotherapy performs better in the anterior tumors than it does in the posterior tumors. And I'm glad that in Brazil there is the irreversible electroporation, which is a non-thermal energy, sort of an electrical current between the two probes that creates pores within the cell membranes and causes the denaturation of these cells. So that energy is carefully controlled to the area that we plan on treating. And so it does well in the anterior, it does well in the posterior tumors, it also does well at the apex. However, it has to be recognized that the experience with this energy is limited, and we need more studies, more experience and more follow-up to be able to see how it compares to the other existing energies. But it certainly is promising as the various energies that we have.
Great. And well, patient underwent focal therapy. So how do I follow this patient? Should I follow with biopsy? Should I biopsy the treatment area only, or the whole prostate? How do you do?
Yeah, so unlike radical therapy, like surgery, or for instance, where we remove the whole prostate, we remove the lymph nodes, we removed all the cancer, we reset the PSA to an undetectable level. And so every time we check, every 3 to 6 months, sometimes with more follow-up once a year, we are looking for no PSA. That's how we measure success. So it's a binary results that we are looking for. Focal therapy, the prostate is there. Sometimes even some low-risk cancer is still there. So it's a modified form of active surveillance that we do. So we have to follow these patients with PSA and look at the PSA dynamic. We have to follow these patients with MRIs, because over time we see that the dying area, that necrosis in the part that was treated, is going to be shrinking. We also have to see if there is persistence of cancer with imaging, And then we have to do surveillance biopsies, both in the field that we treated and also in the non-prostate treated, because that prostatic tissue that was not treated on the other side can also develop cancer down the road. That's the natural history of this disease and so forth. And so the follow-up, it's important to have biopsies. Some people are thinking about studying the utilization of the molecular imaging such as PSMA PET to see if we can improve our detection of viable cancer or new cancer in the prostate, and maybe even reducing a little bit the rate of surveillance biopsies.
Currently, do you use PSMA PET for selection or for follow-up?
We use it both at baseline, not necessarily for selection, and we use it for follow-up to help us make sure that we are consistent. In most patients, yes. However, it's still understudied, the utilization of PSMA.
And the first follow-up biopsy, when do you do it?
So it depends on the disease that we are treating up front. It could be at 6 months or a year. Too early, you end up you could find cells that are dying and it makes the interpretation difficult, but usually within a year or so.
Well, thank you very much. Very important take-home message here about focal therapy. Thank you for being here with us.
Of course.
Continue acompanhando a TV SBU na cobertura do 16º Congresso Internacional de Uro-oncologia aqui em São Paulo.